So good morning, everybody. Points south, points north, who are watching on video. And it's really an extraordinary privilege today to have Paul Francis with us, who really is probably the most important policy person in healthcare right now in New York State. And his official title is Deputy Secretary for Health and Human Services, reporting to Governor Andrew Cuomo. And he served I'm going to read his bio, which says that he served in senior positions for the last 3 New York State governors, which is actually an achievement in itself. Before joining Governor Cuomo's administration, he was an advisor on budget and policy for Governor Eliot Spitzer's successful campaign. He served as director of the budget under Governor Spitzer and as director of state operations under both Governor Spitzer and Governor David Patterson. As the senior official in the governor's office with responsibility for health and human services, Mr. Francis provides oversight to all of the health, behavioral health, and human service agencies in New York State, and is a leading figure in policy development that is reshaping how we approach healthcare. He was appointed by Governor Cuomo to the board of directors of the New York State Health Foundation, who has been a generous grantor of ours at the Institute. He serves on the board of the New York eHealth Collaborative, which is the statewide network for sharing electronic medical records, the Greater New York Hospital Association Ventures, and also chairman of the Interfaith Medical Center in Brooklyn, and is one of several people who were asked to help turn that hospital around after it declared bankruptcy. Prior to entering politics and government, Mr. Francis spent 25 years in the private sector in a variety of financial and operating positions, such as serving as CFO for Ann Taylor and Priceline. The broad ranges of Mr. Francis's interests and his committed leadership have had and continue to have a significant impact on improving healthcare in New York State. And as I'm sure he will share with you, his experiences as a patient have also informed him there's nothing greater than to have somebody in policy who knows both sides of the stethoscope. So it's with great privilege that we invite Paul Francis to the podium. Thank you very much.
Well, thank you, and really the privilege is mine. I've known Neil for more than 10 years. He's been a mentor of mine as I've learned about health policy over these last 10 years. The expression of being a pioneer sounds hackneyed, but in Neil's case, it's really an understatement. He's had an enormous impact on healthcare in New York State and will continue to have a large and growing impact. So it's also special for me to be here at Mount Sinai, where, as Neil suggested, I've done a lot of personal field investigation of the U.S. healthcare system over the last 20 years. Because it's an interesting story and because it is grand rounds, I'm going to share with you a story I wouldn't generally share with a general audience. So in 1995, I had ulcerative colitis, and it had never been a serious issue for me, but in about a 30-day period, it went from 0 to 100. And I was sent to New Rochelle Hospital, near where I live, to get intravenous steroid levels you could only do through IV. And the next morning, my colon perforated. And the good news is that I was in a hospital. The bad news is I was in not a particularly good hospital. But they patched me up. And as you know, it's kind of a sport in New York. If you get sick, for people to say, what's the best place in the world for you to go? And there was no question that that was Mount Sinai. So I was at New Rochelle Hospital for a week. When they released me, I learned later I was a sea of infection that was masked by the very high level of steroids that I was on. But they had suggested that I see a surgeon at Mount Sinai for an operation many months down the road. I went in the next week and saw Dr. Adrian Greenstein, who, if he's not still here, I know his son Alex is. And he took a look at me and he said, well, you're not going home. And 3 days later, they operated on me. They took out the rest of my colon, which he described as gangrenous. And I was really quite sick. I was here for a total of 26 days. And Dr. Greenstein would come in every morning in rounds, and he would say, you will get better. And that calming influence really made a huge difference to me. So I came back to Mount Sinai for 3 more operations in 1986 to create a pouch, and it worked very well. For 17 years, I was under the wonderful care of Dr. Asher Kornbluth, who I know teaches here. And, whoops, alarm. So everything worked really pretty well for about 17 years. And on January 5th, 2012, the night of the State of the State in Albany, I was in my studio apartment there, and about 10 at night, I started to feel ill. And by 4 in the morning, I knew that something really was amiss. So I called 911, and I went to Albany Medical Center. I texted my wife, who was in Europe visiting her family, that I was stabilizing, and I woke up 2 weeks later and was told really an incredible story that I had gone into septic shock. All of my systems had collapsed. I was operated on 9 times over the next 13 days to basically just to stabilize me. I had a blood clot in my left arm because of the abdominal cavity syndrome of septic shock, of the body sending the blood to the core, and the medicine they gave me to get my blood pressure up, which constricts the veins. So they couldn't resolve that, so I acquired left ear. And I got ischemia in 8 toes, which subsequently got lopped off here at Mount Sinai. And I really, I'm a miracle really of modern medicine, because they did not think I would make it, but because of the care of wonderful doctors and nurses, I did. And after a month at Albany Medical Center, I came down to Mount Sinai and spent another 6 weeks here. It was kind of a slow recovery. And really throughout that time, was treated with the kind of care that our goal is for all New Yorkers to have. So the cause of this perforation was considered idiopathic. I did not have Crohn's. They'd taken out my colon, so I didn't have colitis anymore. And the next summer, I got another small perforation, this time in Maine, and had emergency surgery there. Came down to Mount Sinai twice later for surgical complications. And they started to realize that this was more like a condition than an automobile accident, getting these perforations. So a lot of work was done by pathologists at a number of different hospitals, and my hematologist at Mount Sinai and a pathologist at NYU, who I sent the slides to, came up with the theory that what I had was lupus anticoagulant syndrome, which is, of course, a misdirect, because lupus anticoagulant syndrome really means that you have excessive blood clotting, too much coagulants. And this was confirmed through work by an even more specialized group of people at Weill Cornell Medical School. And I was prescribed Coumadin, and I still have a very close eye on the warning signs, but it's considered now that it's addressed the underlying problem. So throughout this whole experience, I realized, just how special it is when you do have, really good care. And I went back to Governor Cuomo's office for 6 months to finish a project. I was out for 6 months. And when I left, I decided to get more involved in healthcare through the New York State Health Foundation, through the New York eHealth Collaborative, through Interfaith Medical Center in Brooklyn. When I went back into government in July of 2013 as the Deputy Secretary for Health and Human Services, I left those behind. But those are experiences that have really informed my policy work. So what I'm going to do this morning, I also have to confess, I am from a pre-PowerPoint generation. So I find this format of PowerPoints still a bit foreign, and I will do my best to try to speak to the slides, but some of them these will all be available later if you're interested. They might be more valuable to read than my comments on them. So let me talk briefly about the state's role in healthcare. Most people have no idea what state government really does. The federal government collects all our taxes, the city government provides services from police to schools, but no one really knows what the state does. But in healthcare, the state is really uniquely important, really in many ways more important than the federal government. And that's because of our overarching responsibility for the healthcare system. The state operates as a regulator. It decides what conditions facilities have to meet. It creates the artificial separation between an Article 28 physical health facility and an Article 31 mental health facility, as you know, by having these very integrated operations conducted in separate spaces. New York controls the scope of practice that that nurses and home health aides can perform. The state, through a certificate of need process, decides, in effect, who can enter a market, because you need to have a certain amount of medical equipment to be able to operate in most specialties. New York State also regulates the whole commercial health insurance market. We set rates for the small group market and the individual market. We can use that rate-setting power to create incentives such as advanced primary care. We protect consumers from unfair practices like out-of-network billing. And we cover almost 3 million people through the New York State of Health, which is our health insurance exchange. But the most important role that New York plays in healthcare is as a purchaser, mostly through the nearly $60 billion Medicaid program, to a smaller extent through the $3 billion state health employee program, which covers almost 1.2 million people around the state, public employees and their families. Now, when I was budget director in 2007, there were 4.1 million people enrolled in Medicaid. And today there's over 6.3 million people in Medicaid. And when Governor Cuomo took office, Medicaid spending had been rising far beyond any other category of the budget. And it was really crowding out other important areas of spending. So Governor Cuomo created something called a Medicaid redesign team. He brought all the stakeholders together, said we're going to create a Medicaid global cap. We'll allow Medicaid spending to rise at the rate of medical CPI. And within that cap, you have a lot of flexibility. You guys figure it out. And it worked. It also ended what had been an annual political battle between the large hospitals and labor unions and other healthcare providers and the governor. And it worked, along with a really visionary young Medicaid director named Jason Helgerson. State spending per recipient on Medicaid has declined significantly, over the last 6 years of Governor Cuomo's term in office. The Medicaid redesign team in 2014 morphed into something called the Delivery System Reform Incentive Payment, or DSRIP program. And DSRIP really is not just designed to contain costs like the Medicaid global cap, but really to serve as a catalyst for a fundamental redesign of the healthcare delivery system. And in turn, DSRIP will lead to a value-based payment approach, which will fundamentally change the way health insurance is paid for in New York State. Health care is paid for in New York State. So this morning I'm going to talk a little bit about what is primary care practice transformation, which is this critical part of DSRIP, what the state and federal governments are doing to try to advance that transformation, a little bit about DSRIP and the underlying social determinants of health that DSRIP is designed to address, and how we're going to shift to a value-based payment system over the next several years. So, as I told you, I'm from a pre-PowerPoint generation where you had like a topic sentence and a paragraph. So this is the wordiest slide. But I put it up because I think it is important to really focus on practice transformation. Obviously, is in the eye of the beholder. This is the definition that the state, through something called the Integrated Care Work Group, developed. And it really has two parts. The first is this systematic approach to primary care involving care coordination, care management for high-risk patients, use of quality metrics for improvement, integration of behavioral health and population health management, and marrying that up with a payment environment in which non-visit, non-procedure-based services are compensated so that doctors can provide the types of services that can keep people healthy and not needing to be in the hospital or other types of acute care. You know, the number of primary care physicians in New York is not entirely clear. There's an official New York State Department of Health estimate that suggests there are about 15,000 primary care physicians in the state. I've seen other estimates that there are close to 20,000 primary care physicians. But the point is that it's a much smaller number than specialists, and yet it really is, you know, at the heart of the new delivery of care system that we're trying to develop. There are a lot of challenges in getting to that transformation. Only about a quarter of primary care practices have some level of patient-centered medical home designation. About a third have some kind of value-based payment in their system, and only 40%, according to these NCQA estimates, even have EMR. So we have a long way to go to fully transform the way primary care is practiced. I think you know what integrated care is in primary care practice transformation, because Neil has really been practicing practice transformation before it was called practice transformation. And I'd be interested actually in hearing from you, you know, how you experience the delivery of care in the environment that the Institute for Family Health provides. But I think this is an interesting simplification of what integrated care means. You know, it's preventive care, and the estimates are that people only get about 50% of the preventive care treatments that they really should. It's routine sick care, which really is a question of access. And it's managing chronic care through care management and others, particularly for those who, you know, have conditions that make it difficult for them to do this on their own. So again, this is a slide that might be more valuable to read later, but it's a summary of the vision of advanced primary care, which is very similar to Patient-Centered Medical Home 2014 Level 3, but it has some distinct differences. And it's intended to catalyze a multi-payer approach to value-based payment and to this type of model of care. The multi-payer approach is important because if you're a physician and 20% of your panel is being reimbursed for one set of quality metrics, and 40% being reimbursed based on a second set of metrics, and the rest being fee-for-service, you're less likely to adopt the kind of systems and behaviors that are really necessary to make this all work. So there's a Tower of Babel of acronyms in healthcare in general, and in this area in particular. These are 5 programs that are all really designed to facilitate this transition from the fee-for-service system and a traditional practice of care to one that reflects this modern integrated practice of primary care supported by a system of value-based payments. The DSRIP program focuses on practices that are in the Medicaid program, APC, which is part of our state innovation model, which in turn is part of our larger state health innovation plan, receives about $100 million from the federal government to help practices make this transition. TCPI is a federal program that focuses on larger practices. CPC Plus is a Medicare program, which in addition to providing transition money, helps to give primary care doctors extra compensation for the loss of productivity while they're making this transition to a new mode of care. And of course, you have the macro program for Medicare, which will come into full effect in 2019. The disrupt challenge is to really transform the entire healthcare delivery system. The goal is to change from fragmented care to one that is excessively focused on inpatient care, to a model that's integrated and focuses on outpatient care, and from a siloed system to one where people really are working together. The goal is to reduce avoidable hospital admissions by 25% in 5 years, and to both improve quality and really stabilize costs. There's about $11 billion in total of funding that's available for this disrupt transition. That sounds like a ton of money until you compare it to the $60 billion annual Medicaid program, which is probably part of about a $200 billion economy of healthcare in New York State. And so it's really intended to be a catalyst, not to alone be the only source of funding for transition. But it is an objective that by 2020, 80% of managed care payments to providers will include some element of value in their structure. Disrupt, just as a process, is, yes?
Is any money allocated towards like public health outreach around this, like educating patients about, or like talking to patients about, like, go see your family doctor instead of go to the ER? Like, is there any?
Yeah, there is. I mean, patient engagement is an important part of care transformation, and it's one of the 11 projects from which performing provider systems could choose. So I'm just going to say, disrupt as a process of massive systemic change is really quite remarkable. It has work groups that have involved hundreds of stakeholders and other New Yorkers in its design. It has very structured oversight and collaborative sessions. All of this, if you are interested, and I was talking to one gentleman who's focused on disrupt, all of this is online, including videos of all the presentations that have been made. The perfect student of disrupt would be an incarcerated person with very good Wi-Fi service. So it's not exactly letting 1,000 flowers bloom, but one of the interesting parts of the design of disrupt is that you have these 25 regional performing provider systems. And this will enable different approaches to trying to solve the same problems. And we'll be able to see who's been naughty and who's been nice, who's been effective and who not. One of the undercurrents, 23 of these 25 performing provider systems are led by hospitals. And one of the undercurrent of complaints that we hear from community-based providers, and especially even more from community-based organizations that are providing non-clinical services, is that the hospitals that are leading these PPSs are not distributing the money in the way that the vision called for, but really developing their own integrated system. And to one degree or another, that may be true, and with the passage of the 5 years of the disrupt program, we'll really be able to evaluate that in more depth and make changes. As I mentioned, there are 11 projects that the different PPSs could choose from. The PPSs include not just hospitals, but community-based providers and community-based organizations, typically hundreds in each PPS. And I'm not sure I see here patient engagement per se, but it's certainly an integral part of the of the whole practice transformation program. Now, one of the key focuses of disrupt is to integrate physical health and behavioral health, something I know that Neil has been doing for many years. One of the co-founders of the Institute for Family Health, Yvonne Bryce, is a friend of mine for 20 years. And I visited Yvonne recently at the Walton Family Health Center in the Bronx. And I just have to say, it's really tremendously inspiring to see one of your operations in action and just how effective it is. And of course, it's integrated with behavioral health and physical health. Maimonides did a pilot for the integration of behavioral health and physical health starting in 2010 through a CMMI innovation grant. And it gives us really an empirical ability earlier than the other district projects are probably finished and can be evaluated to see whether it works. And the results really have been extremely impressive. It's reduced emergency department visits by 14%, inpatient discharges by even more, and cumulatively over a 3-year period, just for the 8,000 patients that were a part of this pilot, it's expected to reduce the total cost of care by about $52 million. The MAX series, or the Medicaid Accelerated Exchange Program, which is part of DSRIP, is intended to put frontline clinicians into teams that look at the root causes of problems and empower them to make changes. And the results have been very encouraging. In the first wave of the MAX series, the focus was on superutilizers, integrating behavioral and primary care access, and the results, again, have been very promising. NYU Lutheran and its MAX series project involving integration of behavioral and primary care increased depression screening by 61%, decreased the number of no-shows, increased the number of warm handoffs from the physical health to a behavioral health provider, community health provider, and increased coordination between the primary care practice and the social worker upon discharge. As you know, the Westchester Medical Center project worked with Ellenville Regional Hospital and the Institute for Family Health, focusing on ED visits and opioid use. It turned out that many patients were tracking which doctor would be in the emergency room. They would see which cars were in the parking lot to go in, and they knew who was the easy touch in terms of opioid prescriptions. And the problem was analyzed, root cause was found, problem was addressed, ED visits reduced by 1/3, prescription orders reduced by more than 70%. So twice a year, DSRIP brings together the 25 PPSs for what they call learning collaboratives, where the PPSs tell their success stories, talk about what they're doing. What I'm going to do very quickly is run through just a few of these projects that were described at the statewide learning symposium in Syracuse last month. So the Bronx Partners program is focusing on CBO engagement, dealing with asthma services with one community-based organization, diabetes self-management with another, more process, and again, how you would reach out to people through a third community-based organization. Workforce is another main focus of DSRIP. In many cases, we don't have the workforce to practice the way that the model would call for. Presby hired 8 RNs to serve as care managers. And they established contracts with 3 community-based organizations with 6 community health workers to focus on home and follow-up appointment visits. Mount Sinai, last but not least, has also created an initiative to reach out to and contract with community-based organizations to try to find innovative ways to integrate the community-based organization services into a value-based payment. So health IT obviously is indispensable if you're trying to integrate care and coordinate care. And all of the PPSs really have as a priority creating an IT network among their members so they can, in fact, operate in an integrated fashion. This health IT, and there are a number of different players in the ecosystem, which I'll talk about in a moment, but they're designed to provide alerts, to enable everybody to see a coordinated care plan, for increased patient engagement through web portals, et cetera. This is the dashboard that the Maimonides PPS, called Community Care Brooklyn, has put together. And you'll see in the middle, Healthix and Shiny, and Time Check from Healthix is here, and Healthix is really by far the largest of what they call these regional health information organizations that really provide the interface between the hundreds of different providers in each PPS that are expected to be connected by 2018. So among these 8, they call them RIOs. I think of them collectively as being what we call the Shiny, the State Health Information Network of New York. And it enables data from a provider in any part of the state to be shared with providers in other regional health organizations. It's had growing pains, like a lot of things, but a lot of the key functionality is now available. There are more than 30 million patients available through statewide patient record lookup, and more functionality is being added all the time. There's a lot of convergence in health IT in the same way that you have convergence in just about every other part of technology. So you have health systems, have very, very large health information, internal health information exchanges. You have many of the PPSs, a number of the PPSs, developing infrastructure, which to some people looks redundant to what the regional health information organizations are doing. And then you have the RIOs, which collectively we call the Shiny. One of the reasons why this is so important is it will enable smaller health players to be fully integrated into a health system that wouldn't otherwise be the case without this kind of a public utility. So the ambition of DSRIP, really is enormous. This is a quote because this is a slide from DSRIP, and it describes how DSRIP is ultimately trying to integrate not just healthcare, but really all government services that affect people's lives, from employment to housing, the criminal justice system, education, and of course, social services. And it's exactly the right ambition, but I think there are some limits that people are beginning to realize to how far you can use the structure of reimbursement in a healthcare system to address wider ranges of social problems and social determinants of health. I think you're probably all familiar with the Tom Frieden health pyramid, where most of the spending is at the top in the acute care and most of the influence is at the bottom in terms of how healthy the environment is in which people live. But I also think it's helpful to look at what academics call these 3 buckets of prevention. So the first bucket is the traditional clinical care and the prevention that's provided through that. And that works very well within the traditional fee-for-service system. The second bucket is really what I would call, in many ways, the DSRIP system, to the extent that DSRIP is trying to engage non-clinical providers in addressing social determinants of health to keep people out of the acute care system. And it works well. The paradigm works well when the service that's being provided is for an identifiable individual who is a member of a health system or a member of a health plan. So Montefiore famously buys air conditioners for individuals with COPD so they don't have to come to the emergency room. Same thing for asthma. So they can go to the person's home and remediate the environmental triggers of asthma because they know that they'll have savings for that person, and if they have some risk for that person, they'll be compensated down the line. The third bucket are interventions that help the public at large, and where you can't really trace the economic benefit through any kind of a reimbursement system. So if you have a member in your practice who has obesity, or a health plan, or your practice that has risk, compensating that person for participating in a diabetes prevention program at the local YMCA, that makes sense, and hopefully more people at risk will do that. But the health system will not work in terms of funding bike paths or recreation centers, which would keep the public at large, including many people who are not their members, healthy, or healthy food, which is incredibly critical to health. So the state and local governments will continue to have to engage in traditional public health spending. One of the main focuses now of the health community, it's one of the 2 priorities of the New York State Health Foundation, is to build healthier communities, with the 2 primary focuses being on food access to healthy food and more physical activity. This is, I did not expect to really read the slide, but a good example of this is what's going on in Brownsville, where it's an integrated approach to food and physical activity. This map, if you see it closely, identifies, where there are access to healthy food and recreation. And the state will increasingly be focusing on this as part of its overall health policy. So the most important social determinant in health after employment is probably housing. I spend by far the most of my time in the human services portfolio focusing on homelessness. 50% of the patients in psychiatric beds at Interfaith Medical Center are homeless. If you cannot provide stable housing to people with serious behavioral health problems, you will not be successful in managing their care. Governor Cuomo, in the State of the State this year, announced an extremely ambitious affordable housing program and supportive housing program. The governor committed to build 20,000 units of supportive housing over the next 20 years, 6,000 over the next 5 years. And these supportive housing units will be integrated with affordable housing units in projects such as this one that St. Barnabas is planning to build. And in addition to the housing, it has street-level opportunities to offer services that address kind of wellness in the community writ large. So this is really an incredibly important program. When I look at the homeless problem in New York, it's really 2 different problems. For families, many of them, not all of them, but many of them, they just need a place to live. And it's really a housing crisis masquerading as a homeless crisis. But for many, if not most, of the adults that are in homeless shelters, they have some type of behavioral health problem, substance abuse, mental health, hard to separate the 2 in many cases. And having a significant amount of more supportive housing, we're doing 20,000 over 5 years, the city's committed, or 15 years, city's committed to do 15,000 over 15 years, I think can really make a dent in adult homeless and street homelessness in New York. So all of this is intended to lead ultimately to this continuum of care, from the acute care system with episodic care where we were, to the coordinated seamless healthcare system the district is trying to create, to 3.0, a system that really is integrated even more strongly with the social determinants of health, engaging other parts of the ecosystem, including the criminal justice system, including social services, et cetera. Delivery system transformation and payment reform really are 2 sides of the same coin. I was joking with somebody before that if I didn't know the slides would be posted, I was going to show the famous New Yorker cartoon that I've had in my office for 20 years, where 2 mathematicians are staring at the blackboard. And on one side is this long set of equations, and on the other end of the blackboard is another long set of equations. In the middle it says, then a miracle occurs. And the one mathematician says to the other, I think you need to be a little more explicit here in step 2. So value-based payment is step 2. But they're actually quite explicit about it. There is a value-based system roadmap that really lays out in great detail how we're supposed to get from the old world, where you have all these silos and a lot of value destroyed along the way, to the new world where care is integrated, payment is integrated. People in the system are compensated for providing non-visit, non-procedure services. Now, if you reduce admissions or visits and you don't increase margins, you are going to see a decline in revenue. If you're a hospital and you're doing the things with your health system, and you're doing the things that reduce inpatient admissions, and you're not yet being really compensated for the outpatient services, you're going to see revenue decline, and that can cause real problems. We're already seeing that today. You know, when you think about the whole logic of value-based payment, even when it works perfectly, it's going to have a lot of disruption. When I started this job and I asked Jason, talk to me about value-based payment, he said, well, a perfect example, Adirondacks Health System, their hospital admissions from doing the types of activities that DISRIP envisions, plus all the other things that are reducing hospital admissions with technology and the like, said, have declined by 25%. And the idea of value-based payment is that the health system will capture that 25%. And it will be shared savings where half will go to the community providers and non-clinical community-based organizations, and half will go to the hospital to give it higher margins. And it's pretty clear that you're still going to be 12.5% short in revenue, and you're going to have to restructure. And change is difficult for hospitals, and it's one reason why the state plays a critically important role trying to smooth this transition from an inpatient model of care, to a new model of care. As I mentioned, there is a value-based payment roadmap that CMS has approved. It would be a presentation in and of itself. There are different levels of risk from upside only to in so-called level 3, where a system is taking both upside risk and downside risk in terms of managing a patient. Our goals are, as I said, that by 2019, there will be some type of value or risk connected with 80% of Medicaid payments. There are statewide value-based payment boot camps, which are also available on the web, and they're really exceptional in trying to see how the system is supposed to work. One of the key challenges is that if you're paying for quality metrics and practitioners believe that they have different outcomes for factors that are exogenous to the factors that are included in the input side of the equation, they're going to get very cynical about a risk-based system. And so I expect this will evolve over many, many years, and we'll start out with something that we call value-based, but has a lot of flexibility within it, and ultimately move to a system where our ability to relate the incomes and the outcomes, inputs and the outcomes, is such that you really can take real risk. So this is a high-level overview. I really would love to hear from you what your observations are about practicing primary care, to the extent you're aware of what we're trying to do with DISRIP or practice transformation. What do you think is working? What do you think is not working? And once again, thank you for the opportunity to come back to Mount Sinai to speak to people when I'm not lying on my back, and thank you for what you do.
So we do have time for questions.
We have a situation in New York City where the housing for women who are victims of domestic violence has such a shortage that the only way we can get them into safe housing is to send them to the emergency room. We can't get them help from our offices because they're going to be seen as not acute enough. And when we send them to the emergency room, they kind of have to be bleeding and bloodied and recently injured. And otherwise, it's like a years-long waiting list. So I agree with you that housing is part of our crisis. And do you know if there's anything being done to address this problem?
Well, domestic violence is just an example of how multifaceted the problem is. In the case of domestic violence, typically the woman, doesn't need permanent supportive housing. She needs transitional housing for 3 to 6 months to be able to stabilize and get back in society. There's not enough transitional housing available for domestic violence victims. The governor created an interagency working group on homelessness, and it's trying to take a subpopulation by subpopulation approach. I don't want to overpromise, but it's definitely an issue that has particular diagnoses and particular prescriptions, and it's something that I hope we can improve on in the years ahead.
A big issue that we deal with here in New York City and New York State at large is segregation of healthcare, which is enabled by an insurance system that allows providers to see only private patients with commercial insurance in their private offices and send patients with Medicaid to here at Mount Sinai to the residence clinics. And at Mount Sinai, a number of people who are in this room have done really incredible work looking at the huge differences in care that are enabled and propped up by that system. And I guess I'm wondering, from your perspective at the state level, what can be done to regulate hospitals like Mount Sinai, Columbia, and the many peer academic hospitals that segregate patients based on insurance status, which in New York City is de facto segregation by race?
Well, that's a great question. I was saying to Neil before this incredibly positive experience I had at Mount Sinai, and Neil was saying, and I was saying, we should really be providing that level of care to people in every hospital all over New York. And Neil was saying, you also have, as you described, a big distinction and disparity in the level of care you get at Mount Sinai if you're a private patient like I was, or if you're a Medicaid patient. It's a complicated problem that in a free market system doesn't have a totally easy answer. But what's related to that, I think, is that the state is providing a great focus on improving safety net hospitals. So the care for a non-private patient at Mount Sinai may not be great, but my guess is it's better than at a safety net hospital in Brooklyn. The state has announced a major initiative to try to address the problems of the 5 hospitals in central and northeastern Brooklyn, which collectively receive about $500 million annually in subsidies from the state of New York and still deliver terrible care. The governor announced a $700 million capital program. Northwell, the old North Shore LIJ, is conducting a major study about how we can really transform that system of safety net hospitals. So I think we have to attack it at both ends. We have to try to get the worst of the worst, which is these safety net hospitals, up to a standard where you would feel comfortable going. And we also have to look at the issue you described, which is access to care by all doctors.
I'd like to congratulate you on the work that you've been doing, and especially in relating your own personal experience with the healthcare system. I'd like to share my own experience. I had not as dramatic as yours, thank God for me, but I had a painful nodule under the skin of my arm, and I went to my family doctor. And I thought, she would be able to, remove it in the office. But for various reasons, she referred me to a specialist who referred me to another specialist who referred me to a plastic surgeon who saw me in his office and then decided to remove the nodule in a surgery center run by one of our august institutions, who I won't name. And I had it removed. There was an anesthesiologist for local anesthesia. There was a circulating nurse. There was a PA and a resident and the attending plastic surgeon. They removed the nodule, which thank goodness was benign, and sewed it up very expertly. And I can see in the EOB that the total charges were in excess of $8,000. Now, this is a procedure which I do in my office at the Institute, and I believe our charge is about $250.
Yeah.
There is a obvious And while I paid my 10% copay, which I was a little unhappy about, the insurance paid the balance of it. And there's clearly a very perverse incentive here to inflate these charges. And I'm sure the plastic surgeon was trained and competent to have been able to do it in his office, but the institution he worked for stripped all ability to do that kind of thing because they need to feed the beast, so to speak. So, I'll
Yeah, no, that's, I mean, what you're describing is exactly the problem that we're trying to solve, where you have a fee-for-service system that compensates for volume as opposed to the, bundle of care, to use jargon. You're also talking about one of the real problems of the healthcare system is there's really a complete lack of transparency. And in a world of high deductibles and high copays, that kind of transparency has become a lot more important to individuals. Right now, it's I can't think of another industry that is more opaque in terms of its pricing. Even an Uber car will now tell you what the fare is going to be before you get in the car. So we're looking at the transparency issues. It's complicated in part because of contractual confidentiality agreements between the health system and the payer. But there's definitely a need for much more transparency, particularly on these conditions that can be more, consumer directed.
So it'll be really interesting to see as we move to capitation, if the hospitals that have gobbled up all these private practices and are now have increased the costs of colonoscopy by like tenfold and everything, will now reverse all of this and tell the doctors to put all the equipment back in their offices and go back to the old way of doing things, because that's really the transition that's got to take place.
Yeah,
it's
that's
going
exactly
on
right.
everywhere.
Exactly right.
Thank you so much for your talk. I think that we can all feel your humanism, and I think that's great leadership for where you are. I'm a student here, so I'm pretty naive, but I think an answer that we commonly get when we talk about segregated care and we talk about how institutions perpetuate racism and perpetuate this multi-tiered insurance system is that we have to make safety net hospitals better, which I think is definitely the case. And I haven't, been incarcerated and studied the Strip enough with free Wi-Fi to know it that well. But as far as I know, there's no way that District directly addresses institutional racism. And we talk about diversifying the workforce. We talk about promoting that on a state level. But in terms of the segregated care system, I think we can do better by making the safety net hospitals better. But I would love if the type of leadership that you have, that we feel the humanism of the room, could do things to really hold these big specialty hospitals accountable for really actions that should be illegal. And even, we talk about the hospital's readmissions reduction program. As far as I know, race still isn't adjusted for. And because of that, race, ethnicity, and a number of 21 factors that have been studied in that JAMA paper, I think that because of that, we see safety net hospitals being penalized more, and hospitals like Sinai, like NYU, like, the many specialty hospitals sort of reaping the benefits, and we send those patients to the safety net hospitals with less resources and continue to segregate within the hospital itself.
Well, I mean, look, it's a great point, and actually, I have to say, I have not focused as much on the disparity within the big academic medical centers, and I really would maybe afterwards love to hear more about you and the other, questioner thinks of some of the things we ought to do. And you're right about, I have spent a lot of time on safety net hospitals, but here's kind of there's a story that to me is kind of a metaphor for the problem. So one of the hospitals, the safety net hospital I won't name, was talking to me about their business, and they said, 55% of the babies here go to the NICU, 10 times the national average. I said, well, it's high. Why is that? Well, There's 3 or 4 hour lines for the maternity clinic downstairs. So, 50% of the women have no prenatal care. And he's continuing to talk about their business. So, we do 45 or 50 kidney transplants a year, down from 100. So why down from 100? Well, we had a few mortalities, but these people couldn't get kidney operations anywhere else. So I said to him, well, just to play devil's advocate, why wouldn't you close the kidney transplant operation, take the money you save, and open an OBGYN clinic in the community, so you wouldn't have 3 or 4 hour lines, and you'd have more prenatal care and fewer babies going to the NICU. So all these people wouldn't be able to get kidney transplants anywhere else. So it's an issue that I think we have to kind of work through the whole ecosystem of to try to solve. That said, I do think what we're going to try to do in Brooklyn, which is really to integrate and rationalize the excess capacity in hospitals, build up a much more robust ambulatory care network with a much more robust health IT system to be able to manage care, and focus in the way that $2.5 billion is spent on these hospitals in central Brooklyn in a way that can address some of the other social determinants of health. I think that's part of the answer for safety net hospitals, but it's a multifaceted, incredibly hard problem. One thing I will say is the reflex solution, which is to increase Medicaid rates, I don't think is the right answer. If for one thing, it's a zero-sum game that would take money from hospitals like Montefiore and Maimonides that are very high public pay. So it's a very multifaceted problem. We just continue to have to try to solve piece by piece of it, and hopefully collectively you have a solution.
What value-based payment seems to translate to us is, as a in the trenches clinician, is doing a lot of extra check boxes in our medical record so that there can be documentation that can be pulled out to say that, yes, we counseled about this, and we screened for that, and we ordered this at the right interval, and made this referral for smoking cessation, checked on depression. It's a long list, and it's getting to be a longer and longer list, and it's beginning to feel like we are checking boxes instead of seeing patients. And it's getting hard to be very well satisfied with providing primary care when not only is the checkbox list growing, but the time we're supposed to do it in is constricting, because we're supposed to see more people at the same time we do more checkboxes and then wash our hands for 45 seconds.
Yeah. Well, I hear that.
Notice she mentioned the hand washing piece.
I appreciate that.
That was the most important part.
I appreciate that. Well, it's a complaint that I hear more, and other people tell me they hear more from physicians than any others, that this system of care and the electronic medical records has fundamentally changed the dynamic of interacting with people. One of the things we can do is to create better alignment among these systems, so you're not checking 150 boxes for 5 different kind of value-based payment approaches. And that's something that the advanced primary care system was designed to try to do. But more fundamentally, I guess I would ask you, what is the alternative to having this kind of structured approach, which may be overly structured? But if you don't have any kind of structure, how do you get confidence that throughout the system, people are providing care in the way that you would do it with or without a structure? Yeah, fair point.
They're not a guarantee that something's actually happened in the exam.
Yeah, very fair point.
On the other hand, we wouldn't go back to the old system of illegible paper records for all the money in the world.
I think what we're seeing is this growth of documentation with no designated documenter, right? And by de facto, it's the physician. But I really think that, a lot of medical systems are using medical scribes, which it seems a little bit silly, like you have a computer and then you have a person to deal with the computer. But I think that might be a necessary component of this is, you want the doctor to do the doctoring, not the documentation. And so I think we're paying physicians at physician rates to do documentation, writing down what happened services, or they're doing it at home after hours, which is a really good way to lead to burnout. So I think we really need to rethink like what our support staff looks like. Like maybe I take the blood pressure and someone writes it down. Like I would prefer that, and have someone in the room with me to be documenting what we're doing rather than be responsible for documenting and doing the mental work of being a clinician at the same time.
Yeah, it's a great point. I guess I'd have two answers. The first is, it is part of the team. You know, when I think I asked Yvonne once, you know, how many doctors do you have? And it's the wrong question. You know, how many people in total do we have that are involved in this continuum of care? The other, and Tom Check probably could speak to this better, is I think we're still in the early innings of a lot of this technology, and one hopes that it will get better in the years to come. So it is more intuitive. It does require less work. But again, the problem you're describing is very much a familiar complaint today.
Last question.
Thank you very much. I'm just wondering about the premise of the risk-sharing model, especially for primary care physicians. The challenge that we have is if there's that, again, if we have this data and sort of the total cost of care is capped, many of us who are in practice are faced with this dilemma of the economic impact of decisions that we make.
Yeah.
And will this lead to a loss of revenue for us?
Yeah.
And, you know, we sort of understand and can appreciate where you're headed, where we're all headed with value-based payment. But it does present some ethical dilemmas for those of us where a patient might say, well, is there an adverse economic impact of whether you order this test for me or not as a provider?
Yeah.
And, in some ways we're becoming insurance companies in addition to being healthcare providers. So just comment on that.
Yeah, well, it's a great point at two levels. First of all, any capitated system is going to create the dilemma of what's inefficiency and waste and what's an extra layer of protection. But on the risk question, one of the challenges for value-based payment is it implicitly depends on very large risk pools. So a primary care doctor who has followed this a lot said you really need to have at least kind of 15 physicians to have a large enough risk pool for this stuff to even begin to make sense. I suspect what will happen is that value-based payment, and I think MACRA is kind of going in this direction. The value-based payment will be more tied to the inputs than tied to the outcomes, because there's just too much variation in terms of outcomes. So at least for many years, until there gets to be, a stronger correlation between what you're doing and what the health outcome is, particularly for small practices, I think they're going to have to adopt a paradigm of focusing on the inputs.
Yeah, and I think that's particularly true for folks that are taking care of folks that have a lot of social determinants. Yeah. Because until we have risk adjustment models, which we really don't have, that your point is really well taken. I just want to thank you. This was very enlightening, and I think you could tell from the questions. There's just so much to learn in this, and every time we hear from a person like yourself, we get to hear different perspectives on what's happening. You can't hear this stuff too many times. So we really thank you so much.
Yeah, well, thanks all of you.